Thanks for joining the CBC seminar series. Really happy to have Dr. Swati Patel here to present today. Dr. Patel got her medical degree at the Albany College of Medicine in New York, and she also has a master's degree in health systems. We're very happy that she came to do some residency training here before also spending some fellowship time in Ann Arbor, and we're excited to have her back, that we were able to lure her back. And she does some really interesting work around colorectal cancer, hereditary cancer syndromes. And, you know, one of the first times I had the opportunity to meet Dr. Patel was on Zoom when we were during COVID, and she was discussing some of her work and trying to identify high-risk individuals, perhaps genetically high-risk individuals from within a sample of people who are participating in normal risk screening behavior in order to potentially up the ante on the rigor of their screening activities. But her work has been funded by NCI, ACS, PCORI, VA, and she has some responsibilities at the VA as well. But she's a really robust contributor scientifically, community-wise, is involved in the National Colorectal Cancer Roundtable and other things. May or may not have spent some time at the White House for good reasons, not for bad reasons. But Dr. Patel, we're thankful for you to be here and to present your research today.
Thanks, Jamie. Really flattering introduction. I was at the White House in March for Colon Cancer Awareness Month in January. You know, I think I'd like to talk about what the work that we've been doing as a research group in improving identification and management of patients at really increased risk of cancer based on family history and genetics. These are my disclosures. The work that we'll be talking about today is funded by our cancer center, the Cancer League of Colorado, and the American Cancer Society. I guess the disclosure that I didn't put up there is that I'm a clinician. A lot of my talks have colonoscopy photos. I know we're, you know, at lunch. I've tried to keep those to a minimum, but hopefully this will be interesting to all. I'll spend the kind of first bit of time just bringing you into our world. I know, you know, everyone comes from a lot of different backgrounds, but I think this is a topic, I'm biased, of course, it's near and dear to my heart, but I think relevant to all of us in the room. And then I'll talk about some of the recent work that we have been kind of pushing out for publication and kind of dissemination. So we know that when we think about solid organ cancers, whether it's colon cancer, breast cancer, ovarian cancer, this is kind of a pie chart that keeps coming up. That probably around 60 to 70% of the time, these things just happen. Maybe a quarter of the time, there's some familial component, and 5 to 10% of the time, there's some clearly identified inherited genetic predisposition. So you might say, well, gosh, if the vast majority of cancer is happening in non-hereditary patients, why are we focused on these patients? And I'd like to try to just make that case to you before I talk about some of our work. Well, even though it's a small piece of the pie, it's a big pie, right? For example, colon cancer, second leading cause of cancer-related death in the top cancers. And these patients that have these genetic or hereditary syndromes, because of their inherited risk, are at significantly increased risk of cancer compared to the general population. And so, for example, Lynch syndrome, which is the most common inherited cancer syndrome, you can see carries a substantially increased risk of cancer, colon cancer, compared to the general population. But this actually is the case across multiple cancers. So these individuals are at significantly increased risk of multi-organ cancer. And the nice thing for those of us who get to take care of these patients is that we can actually help them. You know, this is not a foregone conclusion or you know, foretelling demise. We have a lot of opportunities for prevention, cancer interception, all the way through, you know, survivorship. And so in the prevention realm, Certainly, we know that there are scenarios in which risk reduction surgery is really important. And so, for example, patients with Lynch syndrome who have a really high risk of uterine or endometrial cancer, if you don't have an organ, you can't get cancer. And so if we know about this, we can recommend appropriate risk reduction surgery for certain patients. We know that there are medicines that can significantly reduce the risk of cancer in these high-risk groups. And so we don't really recommend aspirin to the general population for colon cancer risk reduction. But in Lynch syndrome patients, it's associated with a 50% long-term risk reduction. And so it's a really important part of their cancer prevention strategy, such that we only have to treat 24 patients with aspirin to prevent one colon cancer. It's an incredibly impactful intervention. There's data that resistant starch, which our nutrition dietitian group has kind of come up with a really nice way that patients can get this in, but resistant starch intake for these high-risk patients decreases the risk of upper GI cancers, gastric cancer, pancreatic, small bowel, biliary cancers. And then there's emerging evidence that exercise, just like it is protective and decreases risk in the general population, can be very impactful in our high-risk and hereditary patients. And then, of course, really exciting emerging prevention interventions, such as a vaccine to prevent cancer, which is currently in its first kind of phase 2 clinical trial, looking at the Lynch syndrome patient population. And then, of course, my world, even if we can't employ primary prevention to prevent cancer, we have really effective cancer interception tools. And so colonoscopy, when we do colonoscopy, not only can we detect cancer before it develops, before patients develop symptoms, but we can detect precancerous polyps, these lesions that on colonoscopy we see. Patients usually don't have symptoms from them, but we can remove them. And it essentially interrupts the progression, the natural history to cancer. And so these interventions have shown to be associated with significant reduction in colon cancer incidence and mortality for these patients. Even for patients with these syndromes who develop cancer, we can offer them tailored, customized treatment to not only improve their response rate to the cancer they have, but to prevent a second cancer from happening. We know these patients, because of this genetic diathesis, have an increased risk of getting subsequent or metachronous cancers. And so we actually offer things like more extended colectomy if we know about this diagnosis before their cancer. And then we all are familiar with really the power that tailored treatment has for even patients with distant disease in the form of immunotherapy, which we know works very, very well for patients that have MSI high or kind of these tumors that Lynch syndrome patients can have. So clearly, these genetic syndromes, even though they're associated with a significant increased risk, we have really incredible ways to reduce that risk and reduce the burden of cancer along the continuum through survivorship. Not just that, we know how these things are inherited through the family, right? So if we identify the patient in front of us who's under our care who has this genetic predisposition, we can essentially march our way through their family, identify individuals who might be at risk, do genetic testing to find out whether they have that predisposition, and essentially very efficiently go through the family and identify those that have the mutation, and ideally employ these cancer risk reduction interventions, not just to our patient, but to all of their affected family members, and ideally before those family members actually get cancer. So hopefully I've kind of brought you into the world that I live in to give you kind of a broad overview. Even though these syndromes are thought of as a small piece of kind of the overall cancer pie, these patients are significantly affected and these families are significantly affected. And we have really powerful ways to reduce the burden of cancer for these individuals. So to kind of frame some of the things that we've been working on recently, unfortunately, despite everything I told you, hereditary syndromes are really underdiagnosed. This was a modeling study published in 2011. I think we're doing a little bit better than this, but this study estimated that less than 2% of patients with Lynch syndrome in the US were even aware of their diagnosis. Not to kind of give you too much background in our current approach to finding these patients, but generally we rely on collecting and acting on family history of cancer or a personal history of cancer. And, for those who, have some kind of clinical background or even have seen doctors themselves, know how fast-paced that environment is. It's really, really challenging, and it just doesn't get done for clinicians to collect multi-generation cancer family history, let alone document it properly, let alone act on it. And so even though there's really nice risk prediction tools that put together, 3-generation cancer family history and spit out probabilities of having one of these syndromes, they're just not in reality implemented as well as we'd like them to be. And so we also rely on a personal history of cancer. So if we can't find individuals based on their family histories because of these challenges, what about the patients who actually develop cancer? Can we target those individuals to see if their cancer was driven by a hereditary syndrome? And that's really our current approach that works quite well, where we can essentially do screening on colorectal tumors or endometrial tumors to see if they might have a risk for the most common hereditary syndrome, Lynch syndrome, and then navigate them to genomic services like seeing a genetic counselor and getting germline genetic testing. Those are our current approaches. But what about these patients that I see in the endoscopy lab? These individuals who come in maybe for screening, or maybe they have symptoms and I diagnose a really big polyp like this. Although it's a great sort of victory for me when I'm able to remove that and tell the patient that we've sort of prevented them from developing cancer, unfortunately, our current guidelines don't really include these individuals in hereditary risk assessment. They said that you could try or consider doing that tumor-based screening in polyps, but we know the sensitivity is actually really poor for doing that testing in polyps compared to cancer, 70% or less. And so these patients are sort of left in a bit of a donut hole. It clearly is not appropriate to just let that polyp stay in place and turn into a cancer such that they're eligible for risk assessment. But based on these guidelines, and unfortunately cascading based on insurance coverage criteria which rely on these guidelines, these patients don't get hereditary risk assessment. So sure, it's satisfying to take out these polyps, but what drove that polyp formation, and do they have a hereditary risk that we can potentially identify? So there's been some work in this, but it's really limited. We did a retrospective study that kind of estimated that about 5% of patients had a pathogenic variant in a cancer predisposition gene, but this was, really brought by ascertainment bias. These were just patients referred to our high-risk clinic, so probably had some other additional risk factors, and patients who either otherwise met criteria for insurance to pay for genetic testing or, elected to pay for it out of pocket. So there's kind of bias inherently in being able to rely on that estimate. And then similarly, these other studies, the study by Leish et al. Was out of Israel, and again, ascertainment bias because these were individuals who were seen in a high-risk clinic. This biorepository study was a much, much lower estimate, 1.4%. But again, the inclusion criteria were quite broad. It was just individuals who had a kind of billing code, a diagnostic code for polyps. So we didn't even know if there were these advanced polyps or just run-of-the-mill polyps. So, the available data has been quite limited. So we actually don't know what to tell our patients with these advanced polyps about whether they are at potential hereditary risk, the same way that patients with cancer are. So we aim to kind of tackle this question. We wanted to assess the yield of doing kind of contemporary multi-gene panel germline genetic testing in patients with these advanced precancer polyps, advanced adenomas, and then see if we could identify any factors that were associated with having a pathogenic variant in a cancer predisposition gene. So this is a prospective cohort study where we recruited patients from the entire UC Health system who were diagnosed with an advanced polyp between 2011 and 2024. Really kind of hard work of the individuals you can see here to kind of scrub all these kind of colonoscopy reports and pathology reports to truly identify eligible individuals. We excluded those obviously with known hereditary syndromes, people who have had cancer who would otherwise be eligible for hereditary risk assessment, inflammatory bowel disease, which we know increases risk of cancer that's not necessarily genetic, and then obviously people who previously had genetic testing. We extracted demographics. We also did surveys to kind of assess their medical history, their habits, and kind of collected all the data on their polyps and colonoscopy results. Michelle Springer, one of our genetic counselors in the Cancer Center, really performed telehealth genetic counseling for all the patients who agreed to participate in the study. That included collecting kind of a detailed multi-generation cancer pedigree, reviewing advantages, disadvantages of genetic testing, just like we do in our hereditary cancer clinics. And then for patients who were agreeable, they were offered a commercially available multi-gene panel germline genetic test. And so this is very similar to if you came to our clinic, the type of test that we might offer. Advanced adenomas for the non-clinicians tuning in. There's a conventional definition, polyps, by size, greater than a centimeter or so, and then high-risk histologic features, high-grade dysplasia, villus architecture. And this is really just based on data suggesting that patients with these types of polyps have the same risk of, getting cancer, or their first-degree relatives have the same risk of getting cancer as patients with, a family history of cancer. This is kind of based on the American College of Medical Genetics, how, genetic testing results are generally classified as either problem causing, somewhere in between a variant of uncertain significance, or benign polymorphisms. And then we defined kind of clinically actionable variants because, as I mentioned, this is a large panel, 84 to 91 genes. Many we consider high risk or high penetrance associated with an increased risk of different cancers. Some are in this category of moderate penetrance where there might be a slightly increased risk, but not substantially. And then there's the low penetrance conditions where clinical management doesn't change, and the recessive conditions where you might be a carrier and carrier status doesn't increase risk. And then Michelle carefully went through every single variant and looked at the NCI database ClinVar to assess whether there were any conflicting classifications. We kind of summarized our data, standard statistical methods, comparisons between those that have a pathogenic variant versus those that didn't. And so out of all the individuals that were diagnosed with an advanced adenoma that we screened, we ultimately found a little over 1,200 patients in our system who were eligible. They were excluded for a variety of number of reasons. The most common was just that the polyp that they had was not an advanced polyp. And ultimately, after we contacted individuals, and among those who expressed interest and finished genetic counseling, 191 completed germline genetic testing. In terms of the differences between those who agreed to participate versus not, I'd just like to point out that our patients, as is similar with a lot of research studies, were more likely to be women compared to those who didn't participate. And they actually had a higher chance of having high-risk histology on their polyps, suggesting maybe that had been communicated to them in terms of their risk, but there was really no difference in polyp size. So in terms of the folks who finished genetic testing, as I mentioned, the majority, there was a kind of slight majority of female participants. Almost half were under the age of 50. Majority were white, though almost 10% were Hispanic or Latino. And then in terms of their family history, the majority really didn't meet current criteria for genetic testing, and only, you can see that the part that's highlighted, that the majority of this PREM score is that risk model where 2.5% or more is generally where we start to consider genetic testing, but the majority were under 2.5% or didn't even have enough family history to calculate it. In terms of the colonoscopy results, the majority were done for kind of routine screening or prior surveillance. 56% or so had large polyps over 2 centimeters in size. 34% were located in the ascending colon or the cecum, and 60% had sort of villus architecture, and about 26% had high-grade dysplasia. What's important is that majority, 81%, actually just had isolated polyps, a few polyps. So they weren't this like polyposis phenotype of many, many polyps where we think about some of the hereditary polyposis conditions. So what we found is that of all the patients who got germline genetic testing, about 16% had a pathogenic variant. When we break that up into those risk categories, about a quarter were it included these high-risk variants. So Lynch syndrome, which we talked about a little bit. You can see P10, which is associated with the polyposis syndrome, BRCA1, PALB2 associated with pancreatic cancer risk. About 40% had these moderate penetrance variants where there is an association of increased risk of cancer, but not as high as these high-risk variants. And the remainder were these recessive conditions or low-risk conditions where the patient wouldn't actually have any changes in their screening or surveillance. And so that left us with about 10% of patients who had what we would consider a clinically actionable variant, that we do something different for them. We would recommend genetic testing for their family members. And of these patients, only 23% actually met current criteria for genetic testing, though 50% of the ones who had a high-risk variant met current clinical criteria for genetic testing. So if we look at these high-risk variants a little bit more carefully, this first individual is a 31-year-old who had a polyp in his sigmoid colon, villus adenoma, with high-grade dysplasia, didn't meet current NCCN criteria, and was diagnosed with MSH2 Lynch syndrome, so really high risk of colon cancer among other cancers. And when Michelle talked with him and got more of his family history, she actually, learned that, there were some cancers in his family, but they were not first-degree family members. So his mom had breast cancer, but then it was sort of more distant relatives that had colon cancer. And when we looked at his polyp and asked our pathologist to do staining, that tumor screening that we do in cancers, actually there was absence of MSH2 and MSH6. And so maybe tumor screening of that polyp could have been helpful. But what's interesting is that as she got this family history, she learned that one of these cousins, his mom's cousins, actually had a diagnosis of Lynch. It just wasn't communicated to the family. So sort of a failure in our current approach. It was known in the family and it just wasn't really communicated. The second patient with Lynch syndrome had MLH1 Lynch, 32-year-old with a large polyp in the sigmoid. And this patient's family, did actually meet criteria with a PREM score of 6.5. But the patient just wasn't aware. And you can see that the patient's mom had colon cancer, had a maternal uncle with colon cancer, a maternal grandmother with ovarian cancer. These are all typical cancers in Lynch. But when we asked our pathologist to do staining of these polyps, actually all the mismatched repair proteins were intact. So, it's again just showing that poor sensitivity of trying to use the polyps to do tumor staining for these syndromes. This patient had PMS2 Lynch syndrome. She was a little bit older, 45, didn't meet criteria. She did have a family history of pancreatic cancer, but no colon cancer, no uterine or endometrial cancer. And there was maybe hedging by our pathologists about whether PMS2 was present or not. They said attenuation of staining. So just kind of demonstrating that, this approach to try to stain the polyps is probably not adequate. In terms of factors associated with finding a mutation, the things that we sort of hypothesized would be young age, maybe characteristics of the polyp that suggest it's closer to becoming cancer, like high-grade dysplasia. Ultimately, what we found were that there were no clinical factors in our study that were associated with finding a pathogenic variant, not any of these demographics or family history, habits, and really not any polyp or colonoscopy characteristics. With that said, our study was a priori powered to examine the overall pathogenic variant rate compared to those without a pathogenic variant. And we were underpowered to really look at these high-risk variants. But descriptively, when we kind of compared those who had a high-risk variant versus not, you can see that those under the age of 50 were more likely to have a high-risk variant. Polyp size greater than 20 millimeters also appeared to maybe be associated with an increased risk of having a high-risk variant, though histology, villus histology, or high-grade dysplasia really wasn't. So, of course, like with any work that we do, there are limitations. We really didn't intend this study to be evaluating kind of a mechanistic link between these pathogenic variants and the polyp formation. And also, we know that by definition, patients who show up for a colonoscopy are referred. And so it's not necessarily looking at population prevalence, but just yield of a clinical strategy. We didn't have enough power to really look at the high-risk variants, which are the ones of most clinical significance. And then, there's always issues with generalizability. Our best efforts at a prospective cohort study being as inclusive of the statewide health system as possible, we still skewed younger, Caucasian, and with more advanced lesions. But I think nonetheless, our study really is the first in the literature that's prospective in an unselected population that showed an overall yield of about 16%, clinically actionable variants in about 10%. So how does that match up to people with cancer? Well, these are probably the two most widely cited studies in colon cancer patients, where out of Dana-Farber, they had an overall hit rate of about 10%, with high penetrance variants being 5% and moderate penetrance being 3%. They used a smaller panel, so 25 gene panel, whereas this study from the Mayo Clinic used a panel very similar to ours and found a 15% hit rate overall, 6% for high penetrance and 6% for moderate penetrance. And our results are quite similar to the Mayo Clinic study with kind of a similar panel in terms of overall hit rate, high penetrance and moderate penetrance variants. I think we just always have to be humble. As much as it's important to collect family history, it's not kind of the end-all be-all for the presence or absence of hereditary syndrome. Only 20% or so actually met current NCCN criteria for genetic testing. And if we were to kind of do further studies or apply this clinically, I think the individuals under the age of 50 with really big polyps appear to be the group that might have the highest chance of having a high-risk variant. And again, caution with doing tumor-based screening of these polyps. Only one out of 3 of our patients with a high-risk variant had totally normal evaluation of the polyps. So, I think there's a lot of conversations in this space around improving identification of these patients, and we definitely need to push more towards systematic implementation of tumor-based screening of colon cancers, endometrial cancers. University of Colorado is outstanding in this, but that's not necessarily the case at a lot of clinical sites across the country. And there's even kind of emerging questions about, well, if these variants are so underdiagnosed and they can have such a large impact on our families and our patients, what about just population-based screening? And many may be aware that these studies are increasingly happening. Should we just be testing the general population? I think that's quite controversial that the studies are coming out and showing that we can improve detection in that way. But I think as we do that, we should probably also pay attention to kind of the precursors to cancer. And colon is sort of my world, but I think these things exist in other disease entities too, and this may be a target population to improve identification. So that's kind of the first half of what I was going to review with you as to what we're doing on improving identification of these patients. To shift gears a little bit and talk about, well, what happens when we have these patients? They have a really high risk of cancer. We've talked about the things that we think work in decreasing that cancer risk. What more work do we have, in that realm? Well, this is overwhelming, not just for clinicians who are contending with managing this risk, but of course for our patients. And although we, provide them a laundry list of current guideline-based care, it is really daunting for patients to have to implement this. So this is intentionally an overwhelming slide to just show you by syndrome, and even within syndrome by genotype, just how complicated this care is. the different screening tests and procedures these patients benefit from, the subspecialists that need to see them, the surgeries they might need to be talking about, chemo prevention, diet, lifestyle. And you can see there's different ages that things start. Some things are kind of dependent on sex at birth, different intervals, and all of this, of course, customized. And then to make matters even more complicated, the main guideline body that we turn to, the National Comprehensive Cancer Network, we meet yearly. And we update these things yearly. So these things change constantly. So things that maybe a patient was told even 3 years ago is now different. And it's good because it's responsive to emerging data, but just imagine the boat that our patients are in trying to manage all of this. So these guidelines, are just not accessible and actionable to our patients, and oftentimes even overwhelming for clinicians who are not in this space to be able to take care of our patients. So it's unfortunately no surprise that these patients that have these hereditary syndromes have suboptimal adherence to kind of the multi-organ cancer risk reduction recommendations. And so our team really wanted to think about how we can take this sort of tertiary, quaternary care that we provide in our Hereditary GI Cancer Center, where we have a nurse navigator who essentially quarterbacks a lot of this for our patients, where we have clinical champions who sit on these guideline panels kind of to help these patients. How can we bring this to every patient out there? Lynch syndrome is really common. It affects 1 in 279 people. The vast majority of Lynch syndrome patients are not coming to a large academic medical center. And so, over 90% of the US population uses a smartphone. And so we have been really interested in leveraging technology and perhaps building a digital mobile app that can be widely available, accessible to anyone with a hereditary GI cancer syndrome that provides them the support that they need to kind of emulate the navigation that they get at a center like ours. So we partnered with Accords to start to pick this apart a little bit, working with Talia Thompson, Ashley Defoe at Accords, and then Jordan Clausen and Min Do, our 2 internal medicine residents who've really kind of contributed quite a bit to this, with the aim of really understanding the current barriers that our Lynch syndrome patients face in trying to do all of this, and their current systems of care and how they manage it. And then get their guidance on mapping out the components of an app, basically, to help support them longitudinally. So this was a qualitative study. We conducted semi-structured interviews, including Lynch syndrome patients, most common hereditary syndrome, recruited people, tried to cast as wide a net as possible. Initially, recruiting through both social media as well as traditional methods. And so it really was just a single tweet by a low follower PI, but actually got quite a bit of interest and kind of reposts and retweets and shares in other platforms like LinkedIn and Facebook, with a lot of interest expressed. And then traditional methods through our Lynch syndrome patient symposium that we put together with the Cancer Center last year, as well as recruitment through our clinics and endoscopy. We collected just basic demographics, and based on those demographics, tried to do purposeful sampling to kind of get representation as widely as possible. And Talia and Ashley spent 60 minutes with each of these patients interviewing them. And so, as those who are far more kind of familiar with qualitative methods will understand, Talia and Ashley created a code book that was iteratively sort of developed, that we all reviewed together at regular meetings, queried and summarized the data once it was coded, and then kind of developed these summaries of what they found to kind of identify themes that would be components of an mHealth or app. So we ended up interviewing 19 patients. Again, we had a high proportion of women who participated in the study. 84% were white. Most had private insurance and self-declared access to Lynch syndrome specialist care. I think this is just reflective of the individuals who are passionate about participating in research like this. We did get really incredible geographic representation across the US, and I think that was part of our social media recruitment strategy. and about 10% were Hispanic or Latino, and 42% had a prior history of cancer. So what did we learn from them? Well, we learned kind of four main things. The first was that there are major information gaps. These patients, have barriers to accessing accurate and up-to-date information. They kind of are aware that they're potentially relying on non-specific or outdated guidance. They interact with providers who are frequently unaware of the guidelines. And when they seek information, they just get questionable info online and kind of don't know which patient forums to trust. And so they worry about misinformation and different opinions. The second major theme was that their care is really complicated. It's fractured, and unfortunately, it's unrelenting. They're continually struggling with this. So it's burdensome. They have all these time-consuming organizational systems that are both high and low tech. And they just feel like they are the only ones that have to be their own advocate. They don't have support or navigation for the complicated care they have to get. The third thing was that many feel isolated and really seek connection. And they worry that the current forums that exist are unmoderated, misleading, oftentimes anxiety-provoking. And some, also just felt they had to withdraw from them because they're intense and are stressful. The fourth theme was that they had a lot of challenges sharing their information. They're getting these tests and procedures constantly, every year, every few years. And if they move systems, they have a hard time sharing that with their new providers. They have a hard time sharing information with their family members. And they just feel like all their stuff is scattered, And so, for example, a patient might get their colonoscopy at some standalone surgical center in South Denver, but then their GYN is at a different office. And then if they have to get a CT scan, it might be connected to a large hospital. And it's all kind of disconnected, and they're the ones that have trouble kind of organizing it in a way they can share. So how can we potentially help them? This was really fascinating to learn, and the barriers that they expressed really nicely mapped out to potential solutions. So for the information gaps, they really are looking for easy to access, up-to-date, reliable, and tailored guidance. And so, a way that this could be translated to an mHealth solution is really to take their current sources of information and try to map that to an app. So many really described reliable sources of information being their genetic counselors, providers with Lynch expertise, patient advocacy organizations. But unfortunately, they just felt like sometimes the stuff that they got was not necessarily tailored to them, and sought information that was trustworthy, up to date, without being kind of anxiety-provoking or alarming. And so, many were very interested in this information rather than them kind of proactively gathering it from different sources, a desire for it to be pushed to them and pushed to them in sort of a tailored way based on their kind of specific genetic change or their situation, and ideally in a central place where they're not gathering information from all different, potential sources. So you can see how potentially we could take, sort of very, very complicated, dense guidelines and try to simplify them for patients. For the second barrier, complex, constant, fractured care, patients really sought a centralized location to store all their information, and also a way to navigate and organize themselves, appointments, results, kind of daily tracking to remind them to take certain medications or try to meet diet goals or exercise goals. A place to kind of collect notes or questions so that then when they do have appointments with their providers, they have a place to just kind of pull those things up. Currently, a lot of them, described all sorts of high-tech and low-tech things, including a bag of just all the papers that they've accumulated over the years that they bring to appointments, spreadsheets, calendars, stuff stuck to their refrigerators, and then a variety of different disparate, health apps. And unfortunately, all this stuff they described was really hard to organize, and having a central place to organize this could be very, very supportive and helpful. And so, one participant shared that, she has this very complicated, spreadsheet that keeps track of everything. And she's was like, it'd be wonderful to be able to translate that into an app and adjust it based on what your doctor recommends to your own personal health situation. So you can see how potentially all these different, organizational systems could actually, be, incorporated into an app, just like we use apps for all sorts of other calendar management, reminders, et cetera. For the isolation piece, one of the solutions, kind of thematic solutions that brought forth is that patients seek kind of a social platform with, kind of personal interactions, reliable content, and an ability to connect with others who are going through the same thing. And so currently, many go to patient advocacy organizations, social media, family, but they still describe feeling isolated and felt that oftentimes social media platforms were unmoderated, misleading, anxiety-inducing. And so some of the quotations that stuck out to us are that, many of these folks feel very alone, and they want to not only share their experiences, but be able to ask questions of patients that are in their same boat. And then finally, sharing information. I think our healthcare system is fractured and it's hard to kind of overcome that. But patients really requested and sought a mechanism to share information easily, not just with their medical providers, but also with their family members. And so, currently it's sort of the gamut of printing things out, forwarding things via email, PDFs, or verbal communication. But they really sought ideally a place to store things and then push things out to providers or family members as they want. And so that can really decrease the burden of them and how they have to prepare for different doctor's visits or even communicate things to family. And so clearly, a mobile digital solution could potentially help with that if it's stored in that place where they can then push it out to the people that they want to. There's of course limitations to this work. Most of our participants had access to subspecialty care and were more educated and had a higher degree of education. So our results, we have to be cautious in generalizing the usability of an app based on these things for all patients with Lynch syndrome. But despite this, I think we can conclude that patients are seeking this. It's not just sort of our provider perceptions of the challenges that I, have experienced my patients face over the years, but they certainly are seeking a solution like this, and that can actually be potentially very helpful to decrease the cognitive and emotional load that our patients face in kind of managing their care long term, and promote community and connection with others with Lynch. So for this project in particular, we actually completed interviews with healthcare professionals, including primary care, subspecialists who care for these patients, genetic counselors, to kind of understand from the healthcare delivery perspective how this could improve workflow and help patient care. We plan to work with our mHealth lab on campus to develop a prototype for an app and test it for usability, user friendliness among our Lynch syndrome patients, and then ideally expand it to these other hereditary syndromes, which aren't as common as Lynch, but also have a really complicated laundry list of care that these patients need. So that's kind of a summary of more kind of recent work that we've been working on. There's of course always tons of other stuff happening. There's a lot of work, but there are so many unanswered questions. Many careers worth of unanswered questions. I showed you this, and this is what we quote to our patients. If you have MLH1 Lynch syndrome, you have a 60% lifetime risk of getting cancer. But one of the big questions in these hereditary syndromes across the board is actually what this looks like is this. Number one, there's substantial variation based on genotype. And then number two, it's actually kind of a bimodal sort of risk where there are a proportion of patients who have a really high risk of getting cancer, meaning every year I scope them, I find these big polyps, and even despite doing that, they get cancer anyways. And then there's these patients on the other end of the spectrum where, their families or they, no matter what we do or don't do, actually don't appear to have the same risk or penetrance for cancer. And so even though that 60% lifetime risk is sort of a mean or median of this, This is actually, what the data shows. And, I think what we see clinically too, where there are some families where no matter what we do, just, we hear every year that, oh, so-and-so got diagnosed with cancer, whereas others not as much. And then, variation based on genotype with some of these MSH6 PMS2 patients being lower risk. And so, the question is, all these things that we recommend to our patients, are all of them standing to benefit? Do we really need to scope every single patient every year or do hysterectomy in all patients? Maybe not for some of these patients who are on the low lifetime risk, but how do we sort that out? And so, we really need to understand the genetic exposomal risk modifiers to try to develop accurate, kind of personalized risk adapted surveillance approaches and risk reduction approaches, and understand the impact of primary prevention methods that ideally would be much safer, much easier to provide a population than annual colonoscopy. And believe me, I do colonoscopy, so it's not really such that I think that that's not of value. So we're our site, along with several other across the country, are leading this Lineage Consortium, which is a prospective consortium of Lynch syndrome patients to really understand long-term outcomes in Lynch syndrome, and at the same time collect patient outcomes as well as biosamples. We're participating in this vaccine trial that I mentioned to prevent cancer in Lynch syndrome, looking at multi-targeted stool DNA, which many probably have seen marketed for regular colon cancer, kind of general colon cancer screening, but understanding how that can sort of determine or predict findings on colonoscopy and eventually be a part of colorectal screening to decrease the need for colonoscopy in low-risk patients. And then I'm working with Dr. Elizabeth Ryan on a dietary intervention to decrease cancer risk in Lynch syndrome patients. So certainly have to thank all the patients who participate in this really important work, the patient advocacy organizations who promote our work, support our work, huge team of individuals right here on campus that really are critical to moving this forward. And then, of course, with all of this, just appreciate everyone who not only participates in the work, but cares about our patients and cares about each other. So appreciate everyone's attention.
Are you okay with some questions?
Yeah, please.
I'll go ahead and start. Could you explain to a psychologist what microsatellite instability is?
Yeah, sorry, I flew through that.
No, this is a long-standing question I've had. So this is opportunistic for me.
Yeah, no, so, microsatellite instability is a marker that we can test for in a variety of tumors. I'll just use colon or rectal cancer as an example. And essentially, these tumors have kind of mutations or mistakes are, far more than, tumors that don't have microsatellite instability. So they are hypermutable. And so in Lynch syndrome, we know that patients with Lynch syndrome have an inherited mutation in these mismatch repair genes, MLH1, MSH2, PMS2, MSH6. And if they have a second hit in a colon cell where the second, working copy of MLH1 goes down, then that mismatch repair gene can't make the MLH1 mismatch repair protein. And essentially, mistakes in the genetic code can start building up. And if they're not repaired by other mechanisms, they get passed on to cells moving forward. And so microsatellite instability can happen from an inherited condition like Lynch syndrome, but actually the majority of microsatellite instability is just two successive hits in most commonly, MLH1. And so these patients have hypermutable tumors. And so what that looks like clinically is if you do genetic sequencing on the tumor, they've got mutations all over the place compared to patients that don't have MSI high tumors, where it might just be fundamental mutations in like APC or, KRAS or P53. And in terms of the treatment implications and this whole kind of rationale for the vaccine trial is that, sort of DNA in the cell kind of codes RNA and it codes peptides or protein. Then and so, with microsatellite instability, if without mismatch repair, you get all these abnormal insertions and deletions of code that don't get repaired. And so they then code for these abnormal peptides. And so these tumors just have a bunch of abnormal peptides that are foreign, and the body's immune system recognizes those as foreign and can clear them, immune surveillance. That's what immunotherapy essentially does to these tumors. From the prevention side, we know that these neoantigens, these peptides, are even present in polyps and even normal appearing mucosa. And so that's the rationale for the vaccine, is essentially developing antibodies to these neoantigens that seem to be consistent across different types of organs and different types of different patients. And so you can develop a vaccine to basically boost patients' immune systems against it for immune surveillance in the prevention realm, where we could probably immunotherapy would also be effective at decreasing cancer risk, but it's not reasonable to recommend immunotherapy given all of its cost and side effects for the prevention side of things. But a vaccine, really would be.
So in lung, we're doing immunotherapy, Bob and York and those guys. Is it, you really don't think we could get there to do immunoprevention among high-risk individuals in colorectal?
Well, I think immunotherapy, it just carries a lot of risk, and cost and side effects. So I think, for prevention, I think that U-shaped curve is really important to keep in mind. And these are really common conditions. And so if it really affects 1 in 279 individuals, is it reasonable, feasible, cost-effective to implement something like immunotherapy in that big of a population? Probably not. Maybe there's a subset that we identify who's at very, very high risk and going to get cancer no matter what we do, that maybe might be reasonable. We're so far from even being able to understand the modifiers of risk. But a vaccine, on the other hand, I think is something that could potentially just prime our own immune systems to clear the cancer without a substantial cost or side effect.
I have a question. So I was thinking about with the early identification of patients, like we know they're underdiagnosed, this idea to sort of identify people as high risk and who would potentially benefit from screening based on their colonoscopy results. Is there potential in low resource settings that are more reliant on fecal-based screening tests to sort of, if this is a viable means to identify people, are we just going to do a worse job identifying people in like FQHCs that rely more on fecal tests, or not? Maybe.
Well, that's a good question. It kind of takes us upstream a few questions, right? Because when you do fecal-based testing, what are the test characteristics for those tests to actually identify advanced adenomas?
Mm-hmm.
The sensitivity, for FIT, for example, is around 60%. For advanced adenomas, it's probably around 80% for cancers. And so theoretically, the patients who, through a FIT-based screening program, get diagnosed with cancer the current standard of care is to do hereditary risk assessment in those individuals. For the patients who have a FIT positive and are diagnosed with an advanced adenoma on their colonoscopy, those patients may, if this strategy were, kind of implemented, be eligible. But, it's sort of just the fundamental difference between a FIT or stool-based screening program and a colonoscopy-based screening program. The FIT-based screening program theoretically is designed to screen for early stage cancer. And it actually works well on a population-based level. And those are the individuals that, if diagnosed with cancer, should get appropriate hereditary risk assessment. Now, there's a ton of inequity and downstream kind of variable application of the standard of care that contributes to underdiagnosis of patients, where I don't think we're doing a very good job, and data shows that we're not doing a very good job of universal tumor-based screening, in underserved populations. But that's kind of a different story. So to be honest with you, I didn't talk about, whether our study is going to necessarily change our management. I think it answers the question that we as clinicians have, like when we scope these patients and they have a giant polyp, should I be worried that they have Lynch syndrome? The reality is that although the yield is similar to what we see in colon cancer, I think it still requires, adequate patient selection, because when we do routine screening colonoscopy, we find an advanced polyp in like 6 to 10% of patients, depending on the population. So it's probably not feasible to try to push all these patients into, genetic counseling or genetic testing, since we're not even really yet doing it very well in patients with cancer.
I had a question about family history, because looking at some of those like metrics where you assess risk, and we talked, or you covered like ways to communicate your health status or medical information to your family. But I guess how can we help make that communication within families of, because you mentioned like you had that patient that you tested and they didn't even realize they had family history. So I guess what can we do about that, if anything? I know that's such a loaded question. But.
So Jan Lowry is on vacation, but if she were here, I would just ask her to field that question. I mean, her and Lisa and Axel have been working at this for decades, so this concept of cascade testing, that's the most efficient way to identify these hereditary conditions, right? You find one person, march your way through the entire family, and we're doing a terrible job at it. To just take 30 seconds, part of it is a systems level issue.
Yeah.
That, for example, in Australia, they see these hereditary syndromes as a public health issue. Mm-hmm. And so they essentially are empowered, clinicians and the system is empowered to communicate this information to family members, mm-hmm. Just like we would sort of infectious disease, communicable disease risk. The United States is not taking that approach, right? And we prioritize patient privacy. And so, even when we diagnose these patients with these syndromes, our genetic counselors have these amazing templated letters, and they sit down with the patient, they pull out the pedigree and say, okay, how are you going to get this to your uncle? How are you going to get this to your cousin? Formulate these PDFs that are even customized, addressed to those individuals, but it still can't be sent by us, right? The patient has to then send it to those individuals. Mm-hmm. There are some mobile health, kind of websites and things like that where families can kind of log in and then be able to invite people to this. Some of those, have some variable success, but it's still not done well. And you would just think that in the day and age of kind of immediacy and technology that we can find a better way. I have to admit, it's definitely not my program of, research or expertise, but rest assured there's tons and tons of people working on it. And if we can leverage technology to, at least if we're working within the system where the patient has to push it out, mm-hmm. decrease the barriers for them to be able to do so. I think that's probably the way forward.
Swati, thank you very much.